Students, we are entering the last lab. See the picture on the screen. We have to break loose, lot to be covered, and there has to be a sense of urgency. It has all been depicted in this picture in the class on liver. R.A.T.S, racing against time for students in pathology. The first topic for the day shall be biliary cirrhosis. This has been asked as a university question in the form of an essay, short essay, etc. And it is important in pathology, medicine, maybe in certain other questions also. I would like you people to kindly pay an attention to it because this is an odd question which the students find difficult. Recollect the term cirrhosis. Cirrhosis is supposed to be an effacement of architecture. The word kirrhus means hard. It becomes nodular and there is a change in the structure of the liver. And these are the subheadings which we shall be dealing the topic under. There are two types of biliary cirrhosis. One is primary, the other is secondary. There are other terms also such as destructive cholangitis and cholangiolitis. So primarily it is a disorder of the biliary tree. So I would like you people to kindly pay attention. Look at this picture. I find that the paler color is the regenerating nodule and the darker lines are probably the bands of fibrosis which are dividing the parenchyma. Let us have this in mind. Coming to the etiopathogenesis, it is mainly a female disorder. You people will tell me why. Female-male ratio is 9:1. A disorder in the middle age, and it is associated with other autoimmune disorders. That is why the female predilection is there. The antibodies are the IgM antibody, anti-mitochondrial antibody, and there can also be circulating immune complexes. Primarily, it is a disease of the bile duct epithelium. In this, I will be able to see the class 1 and the class 2 HLA antigens. Since it is a disease against self, it is an autoimmune disorder. And there are other associated diseases which can be found in the patient, such as scleroderma, Sjogren syndrome, Zika syndrome, and rheumatoid arthritis. Zika and Sjogren's are more or less an overlap. It is a drying of the secretions. Morphologically, this is what we are going to see. You find that the gallbladder itself and the liver become green due to the stasis of the bile. The capsule of the liver is smooth and glistening. Glistening because it is stretched and shiny. The weight is initially normal, but as the cirrhosis develops, it becomes lesser. There is a fine nodularity or a micronodular cirrhosis. Look at this picture. It is a histological picture in which I am finding the parenchyma. These are the hepatic parenchyma and these are the bands of fibrous tissue which are dividing it. The nodules are of varying sizes and there is an effacement of architecture, typical of cirrhosis. And coming to the gross picture, the first thing that is striking is the hobnail pattern, which is classical of any type of cirrhosis. Secondly, the biliary tinge or the greenish tinge is visible. So these two are the classical features of biliary cirrhosis. Let us have it in mind. Again, the same picture over here. Initially, you find this is a portal triad in which you have got the three structures. Now, there is a periductal inflammation in the form of lymphocytes and plasma cells, leading to initially a destruction of the main bile duct. But subsequently, there can be other proliferations which will be mentioned in the subsequent slides. And here, this is a liver. Externally, I am able to see the nodularity or the hobnail pattern, and the cut surface shows paler and the darker areas. The paler areas indicate the regenerating parenchyma, and the darker lines are the fibrotic lines. And these are the inflammatory infiltrate. Some books call them as portal triaditis. So this is what is classical. I would like you people to kindly draw this diagram. So this is the central vein, the radiating cords of the hepatocytes, and then you have got the bile triad that is found in 3 areas. And in the initial stage, there is a florid ductal lesion. So around the duct, you find that there will be a lot of inflammation. I showed you in the last picture. Then there is a ductular proliferation. The green insets are the lines of proliferation. There are spurs of fibrosis. Look at the strands over here. These start infiltrating into the surrounding parenchyma. Finally, there is a destruction of the hepatocytes, collapse, regeneration, and broad bands of fibrosis which lead to cirrhosis. I would like you people to kindly draw this diagram and mention these stages. It is again given over here. Stage 1 is florid ductal lesion. The bile duct damage is due to inflammation with mononuclear cells. Stage 2 is mainly periportal involvement. There is a disappearance or a destruction of the bile ducts, and there is inflammation involving the portal triad. And stage 3, there is fibrosis. Fibrosis means initially there will be spurs of fibrous tissue, and later on there can be micronodularity. Bile stasis, this is again classical of biliary cirrhosis. Some books call them as bile lakes, which you can see. And stage 4 is there is uniform bridging fibrosis from the portal triad to the portal triad, or the portal triad to the central vein, leading to a cirrhosis. The larger ducts disappear, and sometimes there can be an increased impairment of copper excretion. There is another entity called the secondary biliary cirrhosis. The primary biliary cirrhosis, as we mentioned earlier, is almost an autoimmune disorder. In the secondary, it can be because of biliary obstruction, or it can be because of cholelithiasis, atresia, or the non-development of the bile ducts, stricture, fibrosis of the bile ducts. Secondary inflammation can be there in a bacterial infections or some parasites such as Clonarchus sinensis or Opisthotrochus sinensis. These two are supposed to be different fish tapeworms. As a result of which there can be cholestasis, bile lakes we mentioned, bile duct proliferation, and there can be neutrophilic infiltrate as well as periportal fibrosis. So this is the parasite that we had mentioned. You people will have to read up in your parasitology. This has come as a university question in microbiology. Anyway, that is not my domain. Here I am finding a bile duct that is partly filled with the parasite leading to an obstruction. This is from a human being that the parasite has been seen. They say it is common in countries such as Thailand. These are the clinical manifestations. Pruritus. Whenever there is bile stasis, there will be pruritus or jaundice. Hepatosplenomegaly initially, but then there will be a cirrhosis later on. Hyperpigmentation can be there. Dyslipidemia, distaste for the fatty foods and maldigestion. Portal hypertension. And ultimately, there will be a liver failure. The patient will have to go in for a transplantation. What are all the laboratory investigations? Elevation of the serum alkaline phosphatase, antimitochondrial antibodies, elevated serum bilirubin, conjugated, because it's a type of jaundice. And radiologically, you find that there is a periportal halo. Periportal inflammation and fibrosis will lead to a contraction. Because of that, there is a clear space around the inflammation that is producing a halo. Then a lace-like fibrosis. It is wonderful that radiology is also diagnosing early stages of cirrhosis. And histopathologically, we can do special stains such as reticulin. And then there is an endoscope called ERCP, endoscopic retrograde cholangiopancreatography, which will be able to unleash any form of obstruction. The treatment can be medical in the early stages, ursodeoxycholic acid. Liver transplantation can be the ultimatum, but in the case of secondary biliary cirrhosis, a surgical removal of the obstruction can be attempted at.